Shingles, skin lesion, and shingles are erythematous maculopapular rash that quickly evolve into vesicular lesions. Summary: shingles, herpes zoster is a dermatomal rash with painful blistering that is caused by the reactivation of the varicella zoster virus. The initial infection with varicella zoster virus usually occurs early in life, presenting as chickenpox, after which the virus remains dormant in the dorsal root ganglia. Immunocompromised individuals are at increased risk of varicella zoster virus reactivation. Shingles is generally a clinical diagnosis, although further testing, for example PCR, may be indicated in unclear cases. Treatment with antiviral drugs such as acyclovir is usually effective. Potential complications include encephalitis and, particularly in the elderly population, painful post-herpetic neuralgia. Varicella zoster virus may also affect the cranial nerves. Involvement of the trigeminal nerve may cause visual impairment up to blindness, herpes zoster ophthalmicus, while involvement of the facial and vestibulocochlear nerves can cause facial paralysis and hearing loss, herpes zoster oticus. These presentations in particular require urgent medical attention to prevent serious complications. The recombinant zoster vaccine is recommended for the prevention of herpes zoster in all individuals greater than 50 years of age and immunocompromised individuals greater than 19 years of age. Epidemiology: females are more affected by shingles than males. Etiology: causative pathogen of shingles is varicella zoster virus. Transmission of varicella zoster virus is through respiratory droplets and direct contact with varicella zoster virus infected vesicular fluid, causing chickenpox in those infected. Risk factors for varicella zoster virus reactivation. Reactivation typically occurs in immunocompromised individuals. Decline in immune function with advancing age, malignancy, HIV infection, immunosuppressive therapy, malnutrition, chronic stress. Pathophysiology: primary infection chickenpox, respiratory transmission. Varicella zoster virus inoculates the lymphoid tissue of the nasopharynx and subsequently regional lymphoid tissue. Viremia and chickenpox. Recovery from chickenpox, but virus remains dormant in dorsal root ganglia unless reactivated. Recurrent infection. Reactivation: shingles. Varicella zoster virus reactivated, often many years after the primary infection, for example especially in immunocompromised individuals. Virus replicates in the dorsal root ganglia, travels through peripheral sensory nerves to the skin. Shingles, less contagious than primary infection. Infectivity: shingles is less contagious than primary infection. Only vesicular fluid contains infectious viral particles. Individuals without sufficient varicella zoster virus immunity from primary infection or vaccination are susceptible to contracting chickenpox through contact with blisters. Clinical features: main symptoms, dermatomal distribution, typically affecting 1 to 3 dermatomes on one side of the body, most commonly affects the cervical, trigeminal, thoracic, and lumbar dermatomes. Pain, the most frequent symptom and may precede the rash, usually described as burning, throbbing, or stabbing sensation. Allodynia may occur. Erythematous maculopapular rash that quickly evolves into vesicular regions. Vesicles are initially clear. Pustulation and rupture typically occur after 3 or 4 days. Crusting and involution typically occurs between days 7 and 10. Lesions are no longer infectious at this point. Lesions may become necrotic, generalized, or may not be present at all. Additional symptoms: fever, headache and fatigue, paresthesia, itching, motor deficits. Disseminated herpes zoster. Herpes zoster characterized by more than 20 extradermatomal lesions, involvement of more than 3 dermatomes and/or visceral organ involvement, pneumonia, acute course with dyspnea, tachypnea, chest pain, hemoptysis. Imaging shows nodular interstitial infiltrates, hepatitis, meningoencephalitis, acute retinal necrosis. Typically, disseminated herpes zoster is seen in immunocompromised patients. A typical presentation of shingles, it may be seen in immunocompromised individuals: no rash, recurrent herpes zoster, disseminated zoster. Dermatome map, schematic representation of the body's dermatomes, that is, areas of skin that are innervated by a single sensory spinal root. Herpes zoster, a patient with painful lesions, erythema with vesicles and papules, and a dermatomal distribution T4 and T5 on the back and chest. Herpes zoster, a male patient presenting with solitary and confluent erythematous papules and vesicles on his neck and face, some of which show scaling, distributed along the dermatome C2, C3. The lesions and dermatomal distribution indicate a reactivation of varicella zoster virus. Herpes zoster, shingles. Herpes zoster, numerous grouped vesicles are visible on dermatome T1 by T2, exclusive on the left side. Some vesicles appear hemorrhagic. This appearance, together with its typical distribution pattern along dermatome, is typical of herpes zoster, which is caused by the reactivation of the varicella zoster virus. Shingles of the upper extremity, left arm of a child showing multiple uniform vesicles on an erythematous base. A dermatomal distribution C8 and T1 is characteristic of shingles. Patients complain of severe pain prior to the appearance of lesions. Shingles in a 10-year-old child. Multiple partly confluent vesicles with a strict dermatomal distribution are visible. This appearance is suggestive of shingles. Diagnostics. Clinical presentation is usually sufficient for a diagnosis. PCR of varicella zoster virus DNA, indications, confirmation of herpes zoster, recurrent herpes zoster, atypical presentations may be performed on a variety of specimens. Skin lesions, vesicular fluid. The HFA clean slide should be used to loosen and unroof the vesicular lesion. CSF. If CNS infection, for example meningitis, is suspected, but if there is disseminated disease and a suspicion for viremia, skin lesions, CSF, and blood from all these sample for PCR could be taken. Additional tests to consider: serologic assay of varicella zoster virus, IgM and IgG, can be used to identify active or passive immunity and diagnose primary varicella zoster virus infection. Direct fluorescent antibody of skin scrapings, not routinely recommended because it has a low sensitivity. Zank test of skin vesicles, not routinely recommended because it has a low sensitivity and specificity. Multinucleated giant cells with eosinophilic and trinuclear caudaria inclusions may be seen in Zank test. Patients with recurrent herpes zoster infection or disseminated zoster, consider evaluation for underlying malignancies, immunosuppression, and other causes, for example herpes simplex. Treatment approach: rash onset less than 72 hours. Start oral antiviral therapy for herpes zoster in patients with clear indications, for example age greater than 50 years, moderate to severe symptoms, non-truncal involvement. Start IV antiviral therapy for herpes zoster. For immunocompromised patients, disseminated zoster, neurovascular involvement, for example varicella zoster virus, encephalitis, varicella zoster virus, vasculopathy, herpes zoster ophthalmicus with retinal involvement. These three are the indications for IV antiviral therapy. Antiviral therapy can also be considered in patients without clear indications. Because of the low risk associated with antiviral therapy, treatment might also benefit patients aged less than 50 years in mild symptoms and no complications. Rash onset greater than 72 hours. New vesicles continually appearing. Same treatment as for rash onset less than 72 hours. No new vesicles. Consider supportive care alone for patients with uncomplicated disease. Consider antiviral therapy for herpes zoster in patients aged greater than 50 years with immune deficiency or evidence of complications, for example disseminated zoster neurological involvement. Supportive care: provide routine wound care and adequate analgesia for all patients. Consider adjuvant corticosteroids in select patients. Infection control measures: use airborne precautions and contact precautions when evaluating or admitting patients with suspected shingles. Advise patients to avoid contact with pregnant and immunocompromised individuals and infants until all lesions have crusted over. Trace any at-risk patient contacts for consideration of varicella zoster immunoglobulin. Patients seeking care for suspected shingles should be placed on both airborne precautions and contact precautions to prevent transmission to other at-risk individuals, For example, varicella zoster virus naive or immunocompromised individuals until all lesions have crusted over. Antiviral therapy for herpes zoster. Antiviral therapy speeds up the resolution of lesions, reduces viral shedding, reduces the formation of new lesions, and decreases pain. It is most effective if administered with approximately 72 hours or while new lesions are erupting. Indications of antiviral therapy for herpes zoster: age greater than 50 years, moderate or severe rash and pain, immunocompromised patients, signs of disseminated zoster and or neurological complications, non-bronchial involvement, for example, herpes zoster ophthalmicus. Regimens. For immunocompetent patients or mild uncomplicated disease in immunocompromised patients, choose one of the following: acyclovir, valacyclovir, famciclovir. You can note down doses by pausing the slide or video. Immunocompromised patients and are those with disseminated zoster, IV acyclovir 10 mg per kg IV every 8 hours for 7 to 10 days. Antiviral therapy should be initiated as early as possible since the effectiveness of antiviral treatment decreases as the disease progresses. Anti-inflammatory and analgesic therapy. Pain control is vital to maintain patients' quality of life and prevent post-herpetic neuralgia. General principle: consider prescribing medication regularly, for example, every 6 hours, rather than as needed. Reassess frequently to ensure adequate analgesia and consider using standardized scales to monitor pain. For patients requiring opiate analgesia, change to long-acting formulations once an effective dose is reached. For refractory or severe pain, consider referral to a pain specialist. For possible neural blockade, recommended regimens for mild pain consider one or more of the following: acetaminophen 325 to 1000 mg per oral every 6 hours, maximum dose 4000 mg per 24 hours. NSAIDs, for example, ibuprofen 400 mg per oral every 4 to 6 hours. A weak opioid, for example, tramadol 50 to 100 mg per oral every 12 to 24 hours. Titrate as needed. Maximum dose 400 mg per 24 hours. For moderate to severe pain, add one of the following: a strong opioid, for example, oxycodone. Oxycodone 5 mg per oral every 4 hours. Titrate as needed. Maximum dose 120 mg per 24 hours. Non-triptyline, gabapentin, pregabalin. You can note down doses by pausing the video. Corticosteroids. Corticosteroids. Consider adjuvant corticosteroids in patients with CNS involvement, cranial nerve involvement, for example, facial nerve palsy, herpes zoster otitis, herpes zoster ophthalmicus, especially if there is significant periorbital edema. Severe pain options: prednisolone, prednisone. You can copy the doses by pausing the video. Thank you guys.